Steph. Brilliant. Hi, everybody. So on the stage, we're going to do introductions in a moment, but as Steph has said, the need for evidence-based decision-making is unchanging despite political turmoil. And that's what we're really here to do. How do we inform policymakers with robust and rapid evidence on the questions that matter most to them? Steph's given a bit of an outline around what is a rapid evaluation team. What we've been doing is adapting established research methods so that we can deliver those robust insights on a quicker, shorter time frame while maintaining that credibility and independence. In March, we all came together. Manny kindly hosted us in Birmingham as 5 teams to really share our learnings and reflections. And we wanted to spend some time in this conversation this morning to get into some of those today. We thought about what's been working really well across our units, what are opportunities for improvement, and really fostered that nature of collaboration and collective learning, which we think actually makes all of our work stronger and better. So I'll start by just introducing Reset. So as the chair of this, I'll chip in with a few bits from Reset, but want to make sure that my colleagues share some of their units as well. Confusion around QR codes. There is a Menti QR code on the table, and then I think Holly from our team has scattered some Reset QR codes as well. So if you're interested in learning more about Reset, being on our LinkedIn feed or on our newsletter, please do take time to scan those QR codes. And Rowan, who's very capable comms leader at Nuffield Trust, said, I'm not sure people will sign up to both, so there's a challenge for you all. Thank you. What is Reset? Reset is the Rapid Service Evaluation Team. We're NIHR funded. We were founded in 2018 and crossed 3 organisations, so the Nuffield Trust, UCL and University of Cambridge. We also have a brilliant stakeholder advisory board that really helps ensure we're connected with the system, with providers, with users of our evidence. We have a fantastic PPIE panel that ensure that we are living inclusive research every day. And we have a network of 60 lived experience members that are part of our wider Reset team. A couple of things I just wanted to flag about Reset. One is we really value the independence. So our NIHR funding enables us to be inquisitive and answer the questions that we're looking at in a robust way without being distracted about potentially what other people's agendas may be in that. Secondly, every project we do is mixed methods. We always try and triangulate quantitative, qualitative insights together and have a health economic component. We're very fortunate that the Nuffield Trust has a linked data set that we're able to use, which includes some of the hospital administrative data that helps us to move at pace in terms of understanding the scale of some of the work that we're doing. And I know that data is often a barrier to working rapidly in research, so we feel like that's a huge asset for us. And the fourth thing I wanted to flag is we're generalists. So we've done projects from evaluating a maternity advocacy role for families that have had adverse outcomes in their maternity period, through to patient-initiated follow-up in outpatients, through to AI. We've recently finished a project that Angus has led around the use of AI in chest diagnostics, and we're now mobilizing phase 2 of the evaluation of ambient voice technology. So we work across all different parts of the health system, from system change, role changes, through to AI and digital tools. We have lots of peer-reviewed papers, but I think many of us would feel that's really important for credibility. It's important for our early career researchers. But the things that really make us proud is when our outputs have informed decisions and when others have mobilized the methods that we've used and learned from it. So that's a bit about Reset. I'm going to go to Manny and learn about Brace. And I think we're probably the most similar because we've been around together and long-term collaborators. So over to you, Manny.
Yeah, it feels a lot longer than it should. But yes,
hopefully that's a good thing.
So I'm co-director of the Birmingham, Rand and Cambridge Evaluation Centre of Brace. So we're a collaboration between the University of Birmingham, Rand Europe and National Voices, as well as the University of Cambridge. We've been around and NIHR funded from 2018, and we've completed around about 13 evaluations. At present, we're working on evaluation looking at the contracting and governance arrangements around integrated neighbourhood health, and also doing an evaluation of NHS England's perinatal anti-equity discrimination programme as well, so looking at maternity care. We've kind of learned that issues of equality, diversity and inclusion, as well as patient and public involvement, are cross-cutting themes that run throughout every single one of our projects. It's at the forefront of everything that we do when it comes to inclusivity. Before we've even shaped and kind of responded to any of the kind of issues or kind of dilemmas that have been put forward by commissioners or policymakers. So it's a real emphasis that the work that we do is kind of testament to the patients who are going to be actually using the services at the end of the line. What we try to do is making sure that we kind of build upon our learning from evaluation to evaluation, and that's quite key in terms of how we operate and become responsive. As centres, we don't know what's going to come through our inbox. We are responsive centres and we have to be agile and fleet of foot. And by that, what I mean is we have to be prepared with what might come through and also understand that we may not be the experts. So although we've got a core team, we're very good at actually reaching out to those who know more than us and get them involved. In short, and before I'm going to pass over to Joe, I think we've made a considerable contribution to the literature and also to policy over the last 7 years in which we've been operating. We've informed policy related to kind of, the scientific advisory committees during the pandemic. We've informed care about maternity. We've informed care about mental health in our evaluation of trailblazers and services being delivered for children and young people. We are diverse, and our diversity is our strength at Brace. Joe.
Thank you very much. I'm Jo Donville. I'm a Professor of Applied Health Research at the University of Manchester, and I'm co-director of REVAL, which is, you'll be surprised to hear, another NHR-funded rapid service evaluation team. And you can find out more about us on our website. I feel a bit of a loser not having a QR code today. I'm sorry, you have to go old school. So I co-lead REVAL with my colleague Paul Wilson, Professor Paul Wilson, who is an implementation scientist. And we are coming up to our fifth and final year of REVAL, and this is our first iteration. And like Brace and like RSET, we're generalists and we're responsive, so we get given evaluations to look at, and we work with a range of partners to develop and deliver those as responsively and as rigorously as we can. We've got a broad range of partners that we work with, and some of our public members are here today, which is fantastic, and they're a really core part of our team. So, as other people, we've done lots of evaluations. We'll probably talk more about them in this introduction. At the moment, we're doing the Innovate and Eli Lilly supported OPIP, so the Obesity Innovation Pathway Programme, programme level evaluation. We're just starting. I think that's going to be very interesting.
Thank you. Hello everyone. I'm Sonia Marjanovic. I'm Director of the Healthcare Innovation Group at RAND Europe, and I guess relevant for this event, a trustee of the Nuffield Trust, and I co-lead the DECIDE Rapid Evaluation Centre with Prof. Sarah Shaw at Oxford, who's the PI. We also benefit from a really diverse steering committee, and one of the things that we're really proud of is having a four nations approach, so not hearing just from England, but from the other developed nations, which is really, really relevant for the type of work we do. And we have an awesome advisory group, a user advisory group that spans service users across, or service user representatives across health and social care. DECIDE, unlike the other centres that we've heard about, is a bit more specialised. So our remit is really looking at tech-enabled remote monitoring and wider tech-enabled care. As I mentioned, we're a partnership between Oxford University and RAND Europe. We were commissioned for 3 years. We started in 2023 in July, and in the current form, we're due to complete it. We received a bit of an extension to complete in March of 2027. And our evaluations broadly focus on the implementation, scale, and spread of tech-enabled care. Some of them have looked at policy priorities like remote monitoring. There's been quite a lot of work done on virtual wards. We've actually looked at tech-enabled remote monitoring in primary care and in community settings across health and social care. We've looked at in the area of hypertension, managing heart failure, chronic obstructive pulmonary disease, and we've looked at the use of home sensors in social care. Other evaluations are around tech-enabled care more broadly, so we're leading the national evaluation of occupational health checks, and also we've just kicked off a project on AI-enabled triage. A lot of our work has ended up being a bit more qualitative in nature, mixed methods qualitative. And that's partially because of the nature of questions that were asked, and partially because of the nascency of interventions that we're looking at and the lack of either access or availability of of some of the data that's needed for economic evaluation. But that said, we have also done some economic evaluation work looking at cost of care and uptake in some of the projects that we do. I guess in terms of impact, and before I pass on to Juliette, one of the things that we're really proud of is actually stopping policy from doing things that might not be right. And I think stopping and shifting policy thinking is as important as informing new programs. I think this was most obvious in some of the work we did on respiratory disease and on blood pressure remote monitoring, where we really mitigated against one-size-fits-all, I guess overly generic pathway design. And another thing that I think I'm really proud of, I'm sure we'll come back to this, to impact later on, is just bringing in evaluative thinking into the design, so really early on, before it's too late, into the design of tech-enabled care services that are being rolled out. I'm sure we'll pick up on these themes, so I'm going to stop and pass over to you now, but delighted to be here today.
I think that's a really important point, though, about we should inform what to do, but also what to stop doing. There were a few nods in the audience when you were saying that, so thank you. Juliette.
So hi everyone, so I'm Juliette Malley. I'm a reader at King's College London in the Better Health and Care Hub, which is part of the Faculty of Nursing, Midwifery and Palliative Care. So I'm here today though because I'm co-director of Socrates with Prof. Kath Larkins, who's based at the University of Lancashire. So Socrates is our social care rapid evaluation team. It's a collaboration between King's, University of Lancashire and the LSE. So, like some of the others, we're a 5-year program. We started slightly later though. We started in May 2023, so we've still got quite a bit of time to run. Similarly to the others, we have a great user group who do a lot of work with us. We've got a large stakeholder network that we've set about kind of developing to really support us with all of the evaluations that we do. And our user group is very involved in actually some of the strategic work, helping us think about comms in particular. So different from the other teams is our remit, which is very much social care, but generalists in social care. So we span from children through to adults and also older people. So in terms of what that looks like in our evaluations is slightly different from what the others are doing. So the types of things that we've looked at has been digital technology, so there's a bit of overlap with Decide in that space. We do a lot of work around the prevention, sort of interagency working. We've had a few evaluations in that space. Advocacy around domestic violence, so that feels quite different, I think, from some of the things that others have looked at. Also looking at evaluations around care leavers, trauma-informed approaches to working with families. Mostly those evaluations are sort of more in the implementation space, similarly to Decide, I say, thinking about implementation, how we can think about scaling and spread of some of those innovations or service developments. And then I would say the other thing that sort of sets us apart a little bit from the others is that we're probably the least responsive. We want to be responsive, but responsive in the way that others have talked about in terms of having sort of being asked to do particular evaluations, by policymakers and via NIHR. So we've had to develop a lot of the ideas for the evaluations ourselves. That's involved quite a lot of scoping, prioritization to try and identify what it is out there that would be important to look at and where we can really make a significant contribution. And I say one of the things that, and we'll get onto this I'm sure later when we think about our impact, is that I think for us that's where we feel that we're really having a lot of impact. It's really about sort of surfacing those issues, those areas where, in social care we can make a really important difference by, evaluating some of the things that are going on out there within the services.
Brilliant, thanks Sonia. So we've heard quite a breadth about our different teams and what we're up to. Just want to pick up on some of those themes, and I'm just going to ask Manny first, and then Juliette, actually, we've come back to you. So it'll be really great just to reflect on what we've learned about how rapid evaluation can meet policy and commissioning needs. And Manny, you mentioned some of the impacts that you've had at Brace. Do you want to share more about your learnings on that?
I think it's really important, first and foremost, to actually understand what the need is. Do the actual commissioners or policymakers actually know themselves? And I don't mean that flippantly or kind of antagonizingly, but I really mean that we have to take time to actually understand what we're being asked to do and how we deliver it. So therein lies the real significance that we play on at Brace is the role of scoping. We really take a significant amount of time to understand what the ask is, who do we need to work with, is it actually possible to actually gain access to particular sites or kind of where we need to go? Is it meaningful in terms of, will we make a novel contribution? And how we actually kind of do this is kind of really spending a lot of time with policymakers and commissioners to really get to the nuts and bolts of what we are trying to evaluate. Sometimes, we may have a prior understanding, we may have experience in a particular field, for example, within general practice, but if it's something that's unfamiliar, for example, maternity care in one of our projects, we know that we have to kind of liaise, communicate, engage with a whole range of stakeholders and build and establish our own community of practice that we can engage in to make a meaningful contribution when we deliver our rapid evaluations. So here, it's really understanding of, how I see when topics or projects come through our inbox, we see it as a funnel. We start big, there's lots of breadth, there's lots of understanding and kind of relationships and engagement work that we need to do. We need to engage with our kind of patient and public involvement members, but then we need to narrow down that focus. What is it that we can and cannot do? And we've mentioned earlier already about when do we stop and when do we not do something, and scoping often helps us to determine, we shouldn't overpromise and underdeliver. We should need to be quite clear that this is what we believe that is doable and is related to the question or the ask that's been given to us by the policymakers or the commissioners, and this is how we intend to do it. Sometimes that's agreeable and that's fine. Often there's tension. And I think one thing that I've learned from delivering rapid evaluations and kind of the oversight of them is learning the art of diplomacy and having these conversations in a meaningful, open, transparent way, but in a way that's actually going to lead to evaluations that make a meaningful contribution.
Thanks, Manny. I think some really important themes there. One around that sort of wider network of researchers. I think we're all conscious that we've got hundreds of universities across the country who are doing fantastic work, not always rapid, and we can connect into those teams which you've referred to. And then also that diplomacy really sort of chimes, and I think that's where often we lean on our NHR-funded independence to help us with some of that. Julia, I wondered if you want to share a little bit about social care, because obviously that's a quite different policy landscape than we're talking about with health systems and health interventions.
Yeah, and I mean, sort of getting a sense, well, for us, we were a new team, and it was really important for us, as we've been kind of working through, is to get that sense of, what is our offer? What are the kind of use cases for rapid evaluation in the social care context? And the reason why that's been important is because, like I said, we've had to develop the ideas for the evaluations a lot ourselves. So having that clarity around what it is that we think our offer is, what it is that we think we can do well, and the areas perhaps where it's more difficult to fit a rapid evaluation in. And how we can make that best contribution really in what is a kind of quite a specific context. And social care is a very specific context. So just thinking about the things that differ really, that relationship between the centre and the services is quite different because of that specific role that local government has, developing local policies and the approach to delivery. The role of the VCS, so voluntary and community sector and private providers, also very substantial. Many years of funding cuts, it's very precarious. A lot of services are in a kind of quite a precarious situation. Enthusiasm for evidence, but perhaps a lot less of a culture, and I'm sure we'll go on to talking about this, but also less of a research infrastructure, which really constrains the types of things that can be done. So I think kind of emerging from that, what we've sort of seen are some things that we think it's quite difficult to do in this context in terms of rapid evaluation. It's been quite difficult, I think, to feed into decisions about continuation or rollout policy programs, which I know is some of the areas that you've looked at, in part because there's just been sort of less opportunity. There aren't as many policy programs, certainly in the adult social care context. Might change with the Casey review, but at the moment that's certainly been the case. And also thinking about kind of rollout of policy programs at the local level as well can often be quite difficult because of what I was saying about that precarity that there is out there. So if people are asking us to get involved, it might be already at that point where the decommissioning is potentially a question. So quite difficult to do a rapid evaluation in that context. And I think what we've found in terms of where we think we really can make a significant contribution that really works for policymakers as well as for us and the kind of constraints that there are in the context in which we're operating is really around using rapid evaluation to feed into kind of guidance and activities of regional and sort of local communities of practice, sort of networks that there are around development of services. So the types of evaluations that we're really doing in the space are thinking about, how these innovations are being implemented in lots of different contexts. We're really thinking about creating that kind of contextualized evidence that will help people make those decisions about, well, I've got this innovation. What exactly are the elements that I need to implement? How might I need to be adapting them for the different contexts? So really helping people to make those decisions at a local level. But that's also useful for policymakers at a national level who are thinking about and need to give guidance to local authorities, perhaps also thinking about providers in this space. So this might be, innovations. It might be coming more from a tech push. So, for example, ambient voice technology being a good example of that, but it also might be areas where there's an interest and focus from national policy. So there's a drive on the ground to be doing something in an area. Lots of areas are perhaps, moving in different directions, have some ideas. We can help to bring that together into something that's more coherent to really help to kind of push things out. So a lot of our evaluations now are really in that type of space, which we think is kind of, where we can make a much more significant contribution.
Thanks. I'm going to move us on to some of our methods and approaches, and we're going to come to the floor for questions. So as we're talking, come up with your questions. There's also the Menti QR code, so if you want to start loading questions on that, we'll come to those as well, because we're really keen that we get a chance this to be dynamic. I'm just going to come to Jo, because a key bit on quant is data, and we've talked about all of us are mixed methods, and there's a big role around quantitative research within our mixed methods. Data access, big topic. There's lots of change happening with linked data and different systems being built. Do you want to just share a bit about your experience on enablers of getting access to good data and using it in rapid evaluations?
Yes. I wish I had a longer list. I'm going to say at the start, I wish I had some kind of magic bullet, but I don't, unfortunately. So obviously I increasingly think of rapid research. I know when we started with rapid research, we always used to talk about the 3 R's. So it was, rapid and resources, and I can't remember the other
Manny's
one.
nodding.
Relevance, that was it, and they're really important. And I guess I've almost started thinking of rapid as being a lot about relationships and a lot about responsiveness. So actually the key thing about, I think, our teams is that because we're program funded, we can respond quite quickly, and that allows us to be quite agile and iterative, which I think is really important in this space. And the relationships are really essential. And both of those things, I think, come in around data access, because we have to move very, very quickly, and we have to be quite responsive to the questions that we're going to have to answer in terms of scoping the data that are available. And almost universally, it's a disappointing experience, because you don't want to change the questions based on the data that are available. They're your single point of truth, to start with, I guess, that you've beautifully shaped and co-produced. These are the uncertainties we're going to address. And then accessing data where possible to try and answer the questions that can be answered quantitatively, for us has always been a bit of a struggle, and I could go into a big rant-a-thon. It will be cathartic for me, but not very entertaining for everyone else. And we've heard it all before. We've heard it all before, and there's some great solutions and plans at this level, and I know people who've got great examples of accessing data from secure data environments, and we have examples, but down here where we are, it is a struggle. But the enablers that we found work from us, that we've stolen from borrowed, been influenced by from Brace and Arset, are getting program-level access to things like HES data. The NHS England held routine data sets. So we have, as other rapid teams have, at the reval level, we have program access. So we hold that in the University of Manchester. We're a single organisation rapid team. And it means we have a process, but we can apply internally for access for our programme. So that's much quicker. And I'm also involved in our ARC, and there are very permeable membranes between reval and ARC. And so our plan is to adopt that model for other bigger infrastructure funding, PRUs. We've done it with another national evaluation team. So that works really well, because we're skipping a huge, slow step. And we're getting a lot of support and noises from NHS England around the DARS to facilitate that. So that's great. We've used minimum data sets embedded in rapid evaluation, which has worked reasonably well. Data access is always an issue, but we get better the more we do it. And another enabler that we found, and I'm sure people have better ideas than we do, but we're always trying, is to write analysis plans with code and give it to analysts in NHS England or in other organisations to run. So to try and, using relationships, bridge those gaps between us and the data. And what we'd really like to do is to get researchers embedded in the organisations where we want to do evaluation, and with an ARC hat on, that's what we're looking, as well as programme level access to ICB data, is to kind of try and blur those boundaries. And I know there's some really great examples of people who've done that, but it should be more common, I think.
That's great, Jo, and that speaks a bit about the skills transfer as well, and the ability for the system to rerun some of that analysis if you've given them those code lists and other bits. Brilliant, lots on that. I'm aware, Juliet, that the social care data set is less structured, let's say, than some of the health ones. Do you want to share a bit about how you've therefore adapted your qual methods to try and ensure you've got robust insights, and how that's, what your experience has been?
So, the context in social care is quite different, and the data is not really at that level of quality and consistency. I should say there's been huge investments in data in social care, but still it's kind of not at that space or place where, like Jo, we can, apply for access and so on. So we've had to kind of take quite a different approach with our work, and you can't really have an evaluation where you're going to be relying on, answering the questions through quantitative data. That just doesn't work at all. So the things that we've done is where we have taken a mixed method approach, because we believe it is important to still try to kind of collect quantitative data. That will probably be more through primary data collection within the study, or also through seeing if we can get local data. But that's still highly risky, so you don't want to rely on that. So what we have done is been a bit strategic in how we put together our proposals. In the sense that we will make sure that the kind of core questions of the evaluation can be answered as much as possible using the qualitative data that we know we will collect, and then kind of almost downgrading in a way those questions or sub-questions where it will be answered potentially only through quantitative data because we know there's a risk. But also sort of structuring the way that we collect data within the evaluation to make sure we can see, whether we can answer or whether we can collect the quantitative data that we need, and if we can't, or it becomes very clear, as was the case when we were trying to see if we could do any type of economic analysis in our digital social care records evaluation, it became very clear that we just weren't going to get information about business cases or anything like that from the providers. So we were then able to shift and move towards a more qualitative approach to trying to answer some of those questions. So in that case, we were able to focus a bit more on the sort of cost side of the equation, really trying to enumerate the sort of activities and the items that people were needing to collect or could do to implement these digital social care records. Obviously, that's not the same as coming up with some return on investment or anything like that, but it allows you to at least begin to answer that question in a qualitative way. And arguably, I think actually the type of information that you get out from that is perhaps more useful in a way to providers to really understand, what it is that I have to plan for in terms of the sort of activities, where are there going to be costs in terms of implementing this. So although it doesn't quite give the answer that might be more useful from a policy perspective, from a kind of on-the-ground practice perspective, it's still useful, and just being able to do that pivoting is helpful, I think.
And I think that speaks to the power of using mixed methods in everything we do, because it enables you to make that pivot. We're all committed to inclusive research, and that was a really strong theme that came out when we were together in Birmingham. And aware that there is some sort of structural inequalities, both with quant data availability and accessing communities at pace, that enables you to look at the sort of breadth of representation or engagement that you might want to ensure that we're understanding what works for whom, not just what works for the majority or the easily accessible. Sonia, we've talked before about intersectionality. Do you want to say a bit more about your thoughts about, how can we address some of that challenges about ensuring our research is inclusive?
Absolutely, and I think maybe I'll start with a point which doesn't apply just to inclusive research, but is very, very important for inclusive research and patient and public involvement and engagement. And that has to do with the way we commission evaluations. And often enough, traditional process and impact evaluations will look at what an intervention is trying to achieve, how and why. And rapid evaluations often just use adapted methods to answer that same question. I think what's needed is much more of a framing, an explicit framing of evaluations around areas of uncertainty that need to be addressed and about key obstacles that need to be unlocked. And one of those has very much to do with what cohorts we need to hear from. How do we include seldom heard voices? Otherwise, it ends up being a cross-cutting theme, but never really comes to the fore. So I think that's my first point. On the intersectionality front, the same. When we're trying to engage seldom heard voices, be it in patient and public involvement and engagement or as study participants in inclusive research, no one's just a white man or a black woman or rich or poor. And I think we should be paying more attention to the interconnectedness between different features, including education, socioeconomic status, even cognitive factors, and really just trying to be more sensitive to that diversity when we're sampling and when we're recruiting. I also think, and again, I might be wrong, but this is a personal impression, when I look across the whole body of rapid evaluation research and evaluation studies more generally, when we're thinking about inclusive research, there seems to be a tendency to default to ethnicity and gender, and I think that's because ethnicity and gender receive the most attention. So I think that's an area where improvement is really needed. The other thing
that's where we've got robust data.
Indeed, yeah. And I think there's two more points. I think it's really important to not forget carers. So I would call PPIE, PPCIE. And carer perspectives are particularly important when we talk about engagement with tech-enabled care.
That's a really important point. And I know the Better Health and Care Hub call it the care force. So who's the wider community of staff that act, or who's the wider caring community that isn't just about patients and public, but also recognising the role carers play in the system. Sorry, come on.
No, that's really interesting. I guess one more point, and I think we've been held accountable for this largely by our excellent user advisory group. I think it's really important to mix expert and lay voices, and doing that within the same forum and in the same structure, I think is challenging. So in Decide, what we've tried to do is have at the center level a user advisory group, which is more expert. Hello, Annika, she's been great. Shabir as well, who more kind of expert PPI angle, people who are really experienced in doing this and engaging with research or who are linked to institutions, but then to complement that in projects with pure, in many cases, lay advisory groups. And I think that lay voice is so powerful, not only in terms of informing the questions we want to ask, but how we disseminate and how we engage. I guess the last point on that, I recently did a panel at Rewired, and we had this wonderful lady called Reshma. We were talking about tech-enabled care. And she said, tech is like a fire. It's really useful for cooking, but if you're not careful with it, it'll really burn you. And that just stayed with me. It's kind of like engaging the lay voice really helps us think about how we engage in an accessible format in what we do and how we disseminate. So those are just some reflections on that topic.
Yeah, that's great. Really appreciate it. And I think there is a challenge around representative, and I think we need to be honest, and we were having a reflection on this in our team meeting yesterday with Reset, that we will never be representative around our PPIE panels, but we are really committed to having access to wider voices. Indeed. And Manny, I'm really interested in your partnership with National Voices, which is obviously a huge network of access to voices for all sorts of different topics. How's that worked for Brace?
So I think many of the things and many of our approaches towards inclusivity often are aspirational rather than what we're actually trying to do, and it's really hard and really challenging to implement. And I think what we've tried to establish with National Voices is an organisation that holds us to account. So, we can all talk a good game about inclusion and kind of speaking to different kind of members and engaging with different seldom heard communities, but this is often incredibly challenging. We still have challenges in, recruiting and, interviewing patients as part of our evaluations due to the sensitivity or not doing it in a rushed way and doing it in a meaningful way, and that has tensions with policymakers and commissioners. So often the challenges are quite acute, they're quite kind of at the forefront, and they're incredibly challenging to address. So National Voices often, as a collaborator with Brace, and they intersect all of our projects, holds us to account to say, have you done enough? You said you were going to do this, could you have done it differently? They ask us meaningful questions that kind of pose challenges and questions, not just to the way that we shape our research questions, but to study design overall, and how engagement should be done as opposed to will be done, given resource resource boundaries. So as evaluators, I think we need to provide organisations like National Voices, whether it's People Street or others alike, kind of three things. And first is to kind of give them priority. They should be at the table when conversations are had about design, shaping kind of questions, about engagement, about kind of data collection, data analysis. So we have to give them priority. Second, we have to give them space. Actually give them time to actually kind of bring forward ideas and kind of shape them, engage with their own networks and how they may want to do that. And the third thing I think we should do is kind of give organisations like National Voices opportunities to be novel, to give us ideas and kind of moving away from the tried and tested road and to do things differently. And I think that might give us some ways of kind of engaging with different approaches, different ways of engaging with different communities, rather than simply doing the same thing again, expecting different results.
Thanks, Manny. And I think that point about how we engage and communicate with different communities is really important. And that matters both in terms of shaping our work, conducting our work, but also sharing the impacts afterwards. I want to come to the floor for questions, so start putting hands up for those that have them. And hopefully the Mentimeter is going to come up on the screen at some point. Thanks, Steph. But while I do that, should we just have a quick fire across the four of us, like a quick, snappy response to what's a great example of how you've disseminated one of your projects in a way that you think has helped deliver impact? This is off script, so everyone's going to be like, I didn't take an answer for that.
I suppose, I don't know, I guess I think, so I suppose dissemination feels quite passive, so I suppose I'd say we've focused more on mobilising knowledge, and I guess that is something that is embedded into the evaluation approach, and again, I'm sure this isn't news to anybody here, but I suppose the notion of co-production, which is an element of what we're talking about, and that's co-production with multiple partners, means, again, going back to my rogue R of relationships, I keep banging onto my team, it's people and comms. It's all about who you talk to and how you talk to them and building relationships to support the kind of work that we do. And so I suppose how we've mobilised knowledge is through the relationships and using the motivation that people want in evaluation and the opportunity to do that. And so for us, that's because we tend to evaluate pilot programs, quite large program pilots of programs that may transition into full services. The impact has been trying to provide timely evidence that the end evidence user needs at the point of decision making that's available in that space. And so one of the examples of that is the provision of acute care to people with sickle cell when they're in crisis.
Brilliant, thank you, Jo. Sonia, you've got your hand up.
Just really interesting to pick up on that because it prompted a thought. I think 2 points. One, I think what's helped us is trying to put ourselves in the eyes of a policymaker. And that doesn't mean telling them what they want to hear, but it really means 2 things. It means understanding that they probably need a mix of short-term quick wins when we're thinking about recommendations and longer-term, more aspirational kind of recommendations. And I think it also means recognizing the real linkage between policy and politics. So I think it's quite important. Doesn't mean telling them what they want to hear. In fact, sometimes it's the exact opposite. But I think it's helpful to frame insights and recommendations and try help make the link between those recommendations and the wider policy and political agenda of the time. And then the final kind of point on that, just second point on that, is just discussing very early on the types of outputs that they need. So I think with the NHR...
Okay, just a quick fire, Sonia.
Oh, sorry, I'll
loads
stop.
of questions firing in.
No, I'll stop.
No, carry on if you want. Okay, Juliet.
I mean, I can sort of riff on that in a way, and
Perfect.
just what we were talking about, what Jo, in fact, you were talking about in terms of building relationships. I mean, one of the things that we've done we did it with one of our first projects, but something we've implemented in the others too, is sort of more kind of deliberative style kind of workshops at the end. So we did one as a World Cafe event. So obviously you have the participants in the project, and they're a specific group of people, you can't talk to everyone. But what we did in that event at the end was bring in others who hadn't been part of the research so we could hear their voices as well, so bringing in other voices into a discussion where we shared the results but also co-developed really recommendations that could be taken forward. So policymakers were in that space, the regulator was brought into that space. I should say this was about digital social care records. We also brought providers, we brought all types of people together to really think through the issues and, make sure it was framed in a way that was going to make sense to policymakers and how the sort of policy style perhaps that there is within social care. So that's one way that we've done it, which I think has been quite helpful.
Thank you. Manny?
I'll be quick. It's about
Thanks.
strategy. So who needs to be fed first? Who needs to have certain findings? Who needs to be delivered when, and what impact can be made? Is it policymakers first? Is it case study sites? Is it academics? Really understanding the type of output that needs to be produced for a different stakeholder and the timely impact that can be done. I think the project that we did in collaboration with RESA on COVID oximetry at home and virtual walls is probably the best example of how we achieved impact with various stakeholders, but not just at a single given time, but repeatedly over a number of months. It fed into kind of policymakers, it fed into national policy, we produced a number of academic outputs, but we also had a large resource and a large team, and we had a multidisciplinary team that could actually speak to a different number of stakeholders with not just kind of in a meaningful way, but in a way that was actually engaged and fully thought about and how impact was going to be achieved. And that was only because we had a strategy of how to go about it.
Brilliant, thanks Manny. And I guess I should say that an example from RESA is probably links to Joe's piece about always having a partnership with the evidence user throughout it. So our final reports aren't a surprise. We meet with them regularly. We do workshops at the beginning, the middle and the end to make sure that there's a collaborative process of understanding what's coming out and making sure that that's got utility in the right rooms. So that partnership, I think, with our policymakers has been a real superpower for us. We've got loads of questions coming, and thank you so much for your participation on this. So sorry, team, I'm conscious that we've got so much we want to say. We were having a pre-meet, and I think we got through the first 2 questions while we were discussing in an hour, and then decided that this was going to be ambitious to say everything we wanted to. But we're all around all day, and we're really keen to continue these conversations throughout the session and afterwards as well. Is there anybody in the room that would like to ask a question? We've got one at the front. Is that all right, Steph? And I'm rattling through the Menti one, so thank you so much for that. Multitasking on my phone. And I'll bring some of those themes to the group as well. Go for it. Please introduce yourself as you come in.
Good morning. I'm David Jarram from Health Technology Wales in Cardiff. It's a question mostly for Juliet, but I'd be interested to hear from the panel in health as well as Juliet's views on social care. You talked about proactively going out and seeking questions. That's something we found very challenging to do, to ensure you come back with something that is a priority for the system, but it's still something that is answerable within rapid timelines. So I'd be really interested to hear about mechanisms you've used to do that, please. Thank you.
Thank you. Are there some others that we can collect while Juliet's collecting her thoughts? Go for it, Juliet.
So, I mean, it comes back to, I think, what we've all talked a lot about today, which is about building partnerships and relationships with stakeholders. So I think over time, we've sort of identified what we consider maybe kind of key stakeholder groups who kind of can open the door to lots of other places and people, and it's been really for us about having regular conversations actually with those stakeholders. So we're kind of constantly hearing from them about what are the issues. And then periodically, and we can only do this, we're not resourced in a way to do this kind of prioritization work on an ongoing basis, and that kind of scoping work on an ongoing basis. So what we do is then kind of periodically have a sort of, sort of lay of the land. So where are we up to? What do we understand at this point? Then we go out, we kind of compile that together into a sort of list of things that we've heard are really important issues. Perhaps there's also other things that are coming through from policy at that point. Bring it together into a list of things that we hear are important issues, and then do a kind of very quick survey, sending that out to get a sense of what are the priorities. And again, that's sending that out through those groups that we've identified as being kind of the key gatekeepers really into the system. So ADAS is an obvious one, but we also work in children, so ADCS as well there. People like research and practice and so on and so forth. We've got links into the Principal Social Worker Network and things like that. So there are kind of key groups that kind of help you to open the door, and that's really been the way that we've done it. But it does take resource, and you know, difficult to fit in around when you're trying to deliver rapid evaluations as well. But I think it is important to have that sense both of what are kind of priority areas as well as where are there kind of innovations and interesting things going on. Because if you don't bring those two together, then there's kind of a danger that you go off and look at innovations in a space that no one's particularly interested in and therefore won't listen and won't implement. But on the other side, if you're just looking at priority areas, I mean, a lot of the priority areas that come back to us, particularly, you know, from ADES, they're really big questions. And they're questions that are just not answerable within the context of a rapid evaluation. Sort of like, you know, what do we know about direct payments or sort of personalised approaches to care? You know, that's not really within the remit of what we can do. Really important, but not really within our remit. So hopefully that's been helpful. It's not,
Great. Thank you. And yes, you've got a nod. Good. And I've seen Naomi, you've had your hand up. And if other people have got some, you've got another hand up there. So if we go Naomi and then over to here. Okay, go for it, Naomi. Thank you.
Thanks, everyone. No.
Yeah.
Oh, it is. Oh, brilliant. Hi, I'm Naomi Fullop, UCL and the NHR Reset team. I'll take the liberty of asking the first one on the Mentimeter that I put in, actually. So there's been a lot of talk about evidence for policymakers. And so I'd be interested to hear about how we should balance the needs of evidence for policymakers with organisations and staff that are actually doing the doing. Because I naughtily put in the question, national policymakers are often quite removed from the realities of what's going on at the front line. And Manny mentioned the work we did in the pandemic on COVID oximetry at home. And the phase 1 of that study, which we did in 2 months, someone else has asked about how long these studies take, and that is our quickest one, went to the National Emergency Response Board in the autumn of 2020. But personally, I'm as proud that our findings went to services all across the country in a crazy number of large team meetings to inform and just help people discuss what their services should look like, inform the learning between services. And I think that's a really important role for these rapid teams. There are other teams that inform national policy, and I'm not saying we shouldn't, but you know, how do we get that balance right? Thanks.
Thank you, Naomi. Really important question on how do we balance those audiences of frontline and policy. And I think there's a really interesting adjustment, which Naomi will be aware of in Reset, where we're increasingly being asked to look at budget impact analysis, for example, because if you're doing a project initiation document in a trust, that's the data that you need to put in. It's not about cost per quality. So let's just come to this other question, and then we'll come to the group. Thank you, Naomi.
Natasha Hobbs, I work in the North East London ICB, sort of operational research. We've got really good quant data, so we don't suffer from that barrier. But often the quant data can't tell us very much about outcomes for patients, and where that financial case is difficult to make. I'm thinking something that's on our table at the moment is women's health. We suffer from a lack of sort of outcomes data and sort of proms and prems, and we don't find that that's often used in services. So I just wondered if you have the same finding and how you address that.
Thank you. So should we start with Naomi's piece around policy and frontline? Who are the key audiences and how do we balance those, which are sometimes different questions and different needs? And then thank you from North East London ICB around data. Sonia.
Yeah, happy to pick that up. I think that is a really, really important question, and I could talk about it outside the context of just decide and tech-enabled care, but I think increasingly, in order for service innovations to work, they have to work for all key stakeholders, and that spans service users, it spans the health and social care workforce, it spans suppliers when we're talking about tech as well, because of what they need to design and adapt, and then both national policy and regional policymakers. The way we've tried to do it in Decide, and I can't claim that we've always got it perfect, there are constraints, but these are some reflections on what has learned. So in our COPD work, we tried to share findings and refine them with service users at the end of the project through a workshop, and then worked with them and with a co-design agency to provide resources for patients who are trying to navigate tech-enabled remote monitoring services, and those are available to use nationally. And they kind of focus on, well, these are the questions you might want to think about, these are the risks you might want to consider, how to engage with the healthcare professional. With healthcare professionals, one example I can think of is related to our work on home sensors in social care, actually, where we're just about to publish a policy brief for the Casey Commission. There we went back to frontline staff and people in local authorities as well, and asked them about what they need. So we sensitized them to the findings, and we heard some really interesting things. So for example, one of the things we heard is, don't just give us guidance, give us templates that we can populate, give us something practical that we can use. So really just engaging with the stakeholders and understanding what they need. And same with policymakers and suppliers and patients. I think with service users, one of the biggest misconceptions that we're finding is that they will always know what to ask when they go to seek care. So we very much try to kind of provide resources and guidance that help healthcare professionals engage with service users, and that help service users, I hate the word empowered, but basically be better able to engage with healthcare professionals. Those are some thoughts.
Thank you.
Just add one thing to that, because I agree with absolutely everything you said. I mean, I think, Naomi, in answer to your question, it's slightly easier when you haven't been given a question by policymakers to look at. So, in our context, it has been a bit easier because, policymakers are only one perspective on the question that, we want to look at, or the issue or the innovation we want to look at. And we can make sure from very early on that we're bringing all those perspectives together and making sure that, there's a kind of melange, and then we come up with a set of questions that represent, in a balanced way, the views and things that, equally all those different stakeholders think are important. But I think it is much more difficult when you're given a question, because then it's about much more of a negotiation around what you might want to bring in to make sure it's as relevant to the people on the ground. But I think there are good ways of making an argument about that, because you need the people in the services to be on board with the work that you're doing in order to collect the data and so on. So I think there are strong arguments for making sure that you bring those voices in, it is relevant. I think we were talking to Reset actually when we had that. I think that's something that you do very well and think about too.
Yeah, and I think there is a role potentially for national rapid evaluation teams to advocate for system needs. And Angus and I were in a conversation with our NIHR colleagues yesterday to say, here's a topic that's bubbling up that's really important to service leaders that would make some tangible improvements in frontline care, but we don't yet have the evidence that will enable them to make informed decisions. So I think we can play a role in that sort of interface as well. I hope so. There's lots of fantastic questions. In fact, there's 24. I'm going to rattle through a few of them, and then I'm going to come and close, because I'm conscious Steph was winking at me to make sure I stay on time, which is the key role of a chair, and I don't want to, not honour my obligations. So there were some quick questions of how long does the average project take? Is it getting quicker? Naomi, you've mentioned one of our quickest ones was 2 months. I think COVID was an unusual time of life, but I would say our projects tend to be 6 to 9 months long, probably 12 months for the full wrap-up of finishing papers and the dissemination content, but dissemination continues throughout. How do others feel on that sort of time frame? Joe's smirking at me. That means you're way quicker.
No, the
Similar.
opposite, in fact. I was thinking I should learn to have more of a poker face.
No, that's okay.
So our quickest is 8 weeks. But
There we
actually,
go. 2 months, brilliant.
most of ours, because they run along, a lot of us have run alongside pilot programs, large pilot programs. We tend to start very quickly at the beginning and then have sort of evolved this model for some, but not all, over sometimes a period of 18 months to 2 years, what we call active hibernation. So we'll have periods of really responsive, rapid work, and we're involved all the way along, but often it takes a while for the innovations to get to the stage where the evaluation can bring in earnest. But it's useful to be there. So we're active, but we're not actively active at all points.
Okay, but rapid when you are active. Okay, that's great. There were a few questions about linking to librarians and national systematic reviews and other pieces. Just to reiterate, yes, absolutely we do that. Our librarians are our superpower, and they always have fantastic support for doing literature and rapid reviews. But we always make sure that we're not duplicating. So Prospero is our friend, and knowing what's gone before and where we need to target our energies is very helpful. There were some interesting points which I think we can reflect on on throughout the day about how can people access evidence and information in accessible formats. We know that's evolving at pace. Knowledge mobilisation, Joe, you mentioned earlier, it's not just about dissemination and sort of passive sending out, it's about that relational communication and knowledge mobilisation. There were some bits around national funding. Whoever asked that question, it's on my mind as well. So with some of our team's contracts coming to an end, what's going to happen with national funding? I sadly don't have the answer for that, but I am actively asking. We had quite a few around PPIE and inclusive research. So how do we make sure it's not tokenistic? How do we build those relationships when we're working in a rapid context? And I know we talked a lot about that in March, and maybe this is spoiler alert, but we've got some of those outputs coming out to share more about our learnings around that, and particularly around social care, accessing vulnerable voices. How do we do that? And then I just wanted to, so there's a lot that we can talk about on those pieces, and happy to share more after this session on that. Somebody asked about, do we ever reject projects because they're not rapid? I think Manny and I certainly would say yes. And there is a process of discussion with DHSC and NHS England, and that's obviously a joined conversation at the moment, and our NIHR colleagues to say, is this suitable for a rapid evaluation? And if not, what other paths might they send it down? So we certainly do reject projects that we don't think are suitable for our teams and not using, making maximal value of them. So I speak quickly, I've rattled through some of the 24 questions, but there are more on there that we'll continue to digest. I just wanted to close on a positive piece, because we've talked about impact and we're all motivated by making a positive change, about using evidence to inform decisions. I wanted to ask each of my colleagues, what are you most proud of in terms of impact for the work that you do? Juliet, should we start with you?
Shall I start?
Go
Okay.
for it.
So mine's more of a kind of pathway to impact, I think, in a way. So I've slightly interpreted this question. But for us, I think what we're most proud of, and because it is essential for us to have impact, because as I said, we've had to develop a lot of the ideas for the projects ourselves, is just kind of being on the map. And people out there in the sector at national and local levels knowing who we are, knowing what we do and what we can offer, and having a lot more people kind of coming to us with ideas about what it is we could look at, and just being very clear. We weren't certain at the beginning because no one was asking us to do anything, whether there was any demand for a rapid evaluation team in social care, and I can absolutely, definitively say there really, really is demand for a rapid evaluation team in social care, and I think for me that's fantastic. Kind of pathway to impact, but also impact to be having is to be very clear on that question. Oh, and I covered my microphone, sorry.
Go for it.
I think I kind of covered this in the beginning. I really do think one of our biggest impacts was bringing that social technical thinking and mitigating against overly simplistic rollout of tech-enabled interventions that actually wouldn't be sustained or scaled. Had we not done that? The other thing I'd like to just flag, and this is a role for I think all teams, is bridging that gap between evidence and policy and thinking about how we could do that creatively. So we managed to have a policy secondment at Oxford, and with the Department of Health and Social Care, their digitising social care team, and I think that really helped increase appetite and the pull for the findings. So I'll pause there.
Yeah, I think just echoing what people have said, I suppose we've been able to have kind of the right evidence in the right place at the right time to inform decisions or feed into informing decisions across numerous projects, and so obviously we're really proud of that. But I suppose more widely, it's been great to build a team and have, I suppose, impact in terms of hopefully building future generation of researchers and spreading these ideas. So we're adopting this approach more in our ARC and more widely. So it feels like a really nice way of working, a really productive way of working, and that ethos is spread, I think.
Love that, Joe, thank you.
I think I'm most proud of the kind of methodological contribution that we've made. I think Brace and Reset, we had a bit of a head start on the three of you, so I think we kind of set the road of kind of what we're trying to do and how we're trying to do it. And I think some of the more methodological learning collectively now with all the centres is kind of coming through about how our scoping process, our data analysis, our collection, our approach to inclusivity. I'm really proud of that. I think the thing that I'm most proud of, I think we've produced over 200 outputs from Brace over the last 7 or 8 years, and only about 25 of them are actually peer-reviewed publications. So there's a real importance about actually we need to, if we are going to reach out to different stakeholders, whether it's practitioners, the workforce, policymakers, academics, it's about how we get those messages across, and there's not just one way to do that. There are many different ways, and how we should communicate and translate our learning And it's important that we do that, not just once the project's finished, but repeatedly, so the learning's not lost, but momentum is gained.
Thank you, Manny. And echoing those thoughts, I think we had a midterm review reset sort of away day, and the thing that came across really loudly was that supportive and inclusive culture, both of our internal teams. We work across 3 organisations, but also collaboration with the other groups. And as you've mentioned, Joe, collaboration with other NIHR-funded infrastructure and thinking quite dynamically about what that looks like. So lots to be proud of, which is awesome. It is 10:50, which means it's coffee break time. So please do continue these conversations. Come and find us throughout the day. And thank you so much for your attention and participation in this morning's session. And I should say a massive thank you to my colleagues. So thank you, Juliet. Thank you, Sonia. Thank you, Joe. Thank you, Manny.
Thank you, Jenny.
Thank you, Jenny.
Thank you.